Professor.
Good evening, everybody. Good evening, Alisher.
Yeah, it's nice to hear you here. So I would like to introduce you for our audience in Russian because we are bilingual. And after that, you will start your presentation. It's great honor to host you in our Onco-School. Разрешите открыть сегодняшнюю школу онкологии, которая посвящена лечению лимфом. Название лекции «Эра без химиотерапии в лечении лимфом». И наш лектор является Мохамед Эмам, который, в свою очередь, является консультантом в клинике Ульм. Также он является выходцем из Европейской школы онкологии. В настоящее время он работает консультантом в Национальном институте онкологии Каира. So, dear professor, you can start your presentation.
Okay, can I share my slides?
Yes, here.
Okay. Is it seen by all of you?
Not now, but I think it's starting. Maybe the internet is not so fast. Yeah, now we can see.
Yes. First of all, I would like to thank my colleague, Dr. Alisher Karov, for this kind invitations to present my lectures today on Onco-School dashboard by Djamili Polatova. Thank you for letting me this opportunity, and it's my pleasure to be here with you to discuss a very new topic and very important topic about the role of chemotherapy-free regimens in treatment of the lymphoma, especially follicular lymphoma. My name is Mохамеда Эмама. I am a medical oncologist at National Cancer Institute of Egypt. My topic today about follicular lymphoma, there is any room for non-chemotherapy-based approach. As we see, all of us, follicular lymphoma have a different heterogeneous group with remitting, relapsing natures, and follicular lymphoma outcome was changed in even the last decades, and this data comes from Partis Cancer Institute and the Clinic Barcelona Hospital University, showed improvement of the survival over the years, over the last years. And also we have a pooled analysis from Stanford University experience that showed improvement in the survival in different eras, either pre-anthracycles or after adding anthracycles or more aggressive treatment. And lastly, adding rituximab, the only drug that improved overall survival even as a single agent in treatment of the follicular lymphoma, reaching to overall survival more than 13 years, and this is very fantastic result. Also, we have a very important trial, the PRIMA trial, that used rituximab plus chemotherapy, then randomizing the patient either using rituximab as a single agent maintenance or observation, and this trial showed improvement in the progression-free survival about absolutely 1 year, but unfortunately there is no difference in overall survival in those patients. So from this trial showed adding rituximab to the chemotherapy improve overall survival. But in historical data, like what about adding more aggressive chemotherapy? Unfortunately, adding chemotherapy, adding more toxicity, but not adding more survival benefit. And this comes from these trials, 2016 from Japan and also from Ladeto, like that showed no improvement in overall survival, either by adding more aggressive treatment or more aggressive treatment, either by autologous stem cell transplantation. Before the era of the rituximab, the only trial that showed improvement in overall survival was for adding autologous stem cell transplantation. But after that, there was no any benefit from using this regimen in the rituximab era. In this curve, about 80% of the follicular lymphoma patients have outstanding survival pattern, but the only early progressors that progress within the first 2 years, those have a less progression-free survival and overall survival compared to the normal populations of follicular lymphoma. By this meta-analysis, adding rituximab to the chemotherapy in all these trials showed improvement in the survival compared to chemotherapy. And this is the trials that showed using rituximab as a single agent with overall response rate reaching about 73 to 75% in all trials. The only trials are additional trials 2010 that showed more improvement in overall response rate. But our rationale in this trial, as most of the patients included in this trial was asymptomatic patient, and those patients doesn't need active treatment to start, so the response rate was more in the trial. Depending on this previous data, we have the standard treatment combining rituximab plus chemotherapy, and this makes the treatment more active regarding the different trials, even URTC, LISA, or other trials. But now we have a different approach or alternative approach to improve the survival and the response rate by using rituximab single agent. And this is make it more patient-friendly depending on the different trials like SEG and the Nordic group. From this point, the birth of the chemo-free regimen started to be elicited to the world. So our goal, what is the evidence to have a proposed chemo-free treatment either using rituximab single agent or plus other partners. And in the following slides, I will discuss this. Rituximab first alone as a single agent. We have a trial that published 2014 by combining watch and wait regimen versus adding rituximab, either single agent or single agent followed by maintenance. This trial showed improvement in progression-free survival by using rituximab either induction or as a maintenance therapy, but unfortunately there is no overall survival benefit as we see in the right side in this patient. Another trial, SEG trial, this is the sales group 3598 that showed rule of maintenance rituximab after using single agent rituximab. And as we see, induction treatment with rituximab for 4 weeks. This patient after that who responding randomized to observation versus maintenance treatment with rituximab every 2 months for about 4 weeks. And as we see, adding 4 additional rituximab doses improved event-free survival with absolute benefit about 1 year, and 45% of the chemotherapy responders, naive responders, is still in remission at 8 years, and this is very good result. But with follow-up at 5 years, overall survival in the both groups reaching more than 90% between in using maintenance treatment at 1 year or up to 5 years. And this was discussed in the SEG group trials. And we have a long-term result data analysis that published in 2020 showing about 10-year overall survival reaching 78%. And this is like another chemotherapy approach using combinations of chemotherapy plus rituximab. And this is well discussed also after that. So upfront rituximab in the follicular lymphoma at 10-year overall survival reaching more than 80% in responding patients. And the follow-up at 10 years, 1/3 of those responding patients didn't need additional treatment after using rituximab as a monotherapy. So another trial by Nordic lymphoma group, it is a phase 2 trial using induction rituximab 4 weeks, as we know. Then maintenance rituximab by adding another partners like interferon by the use of 3 million unit at week 1, then 4.5 million unit in the further weeks. And this trial showed overall response rate reaching 78%. But unfortunately, this trial doesn't not powered to show survival data or survival benefit. Why we combine interferon with rituximab? Overall survival data in the last trials was improved in meta-analysis by using interferon plus chemotherapy. And also we have a data that show improvement or sensitizing the B cells by upregulating CD20 and also interferon increase ADCC effect of the rituximab. So that is why we discuss adding rituximab, adding interferon to rituximab in the further trial. Another phase 3 trials also conducted by Nordic lymphoma group by adding interferon to the rituximab, either in the first arm of induction rituximab or either in the maintenance group, and showed at 5 years follow-up, 42% of those responders was still free, with 5-year overall survival 88% in each arm. So the interferon improved the complete remission rate, but unfortunately not improved the time to treatment failure. And then after longer term follow-up of adding this interferon, we have data that confirm interferon didn't improve the outcome of these patients, with transformation reaching about 18%. So till now, it is not a standard of care. And also 10-year overall survival reaching about 78% with single agent rituximab or with adding interferon. When we come back to the data showing the adding rituximab to chemotherapy showed overall survival reaching about 79% to 84%. And this data was compatible to the SEUS data or SAC trial that showed the same overall survival benefit by using rituximab single agent. We need to search for another partner for rituximab. And this is one of the most important trials, bortezomib. This is the godfather and godmothers for chemo-free regimen trials. And bortezomib combination with rituximab is a feasible and safe combination. But unfortunately, the clinical benefit that showed from these trials not so great as expected in the pre-specified analysis of this trial, and also there is no difference in overall survival. Another partners by using lenalidomide combined with rituximab, as lenalidomide, as we see in the mice model, improve ADCC activity of rituximab-treated CD20 tumor cells. And this is curve show with the progression-free survival in patient untreated and diagnosis with follicular lymphoma, either receiving lenalidomide plus rituximab with complete remission rate 87%. And this is very marvelous result regarding the response rate. Another trial, CALGB trial, it is American trials that show the rule of adding lenalidomide plus rituximab in all groups of follicular lymphoma, either low or high or intermediate risk, and showed about overall 5-year survival, 100% of those patients. Also, the SAC trial, 35-10 randomized trials using lenalidomide, adding to the rituximab, and those patients who didn't achieve the minimal response rate for more than 25% to the reduction show continue lenalidomide as a maintenance therapy in the trial. And in this trial, we use the data or the criteria by Gulf trial, who patients who should need to start treatment. And as we see, the criteria needed to start treatment to be symptomatic organomegaly like lymphadenopathy or splenomegaly, or patient have clinical significant progressions over more than 6 months or more than 3 nodal sites, plus each site nodal diameters more than 3 centimeters, bulky disease with more than 6 centimeters in the long diameters, or patient have significant cytopenia, either anemia, thrombocytopenia, or developed B symptoms. And this is also the toxicity profile from the SAC trial by adding rituximab to the lenalidomide, and showed more toxicity profile compared to the single arm rituximab, and also unexpected some adverse events showed in the trial. And this curve showed more response rate, and in adding rituximab to combination to the lenalidomide with more complete remission rate compared to the single agent, as we see. Also, median progression-free survival was not reached compared to single agent rituximab in this trial, and all these trials improved the progression-free survival and the time to the next treatment period, as we see in this curve. Also, we have a data that showed complete remission rate at 30 months, showed 42% of those patients with combinations versus 19 patients with single agent rituximab. But the same 4-year overall survival was the same in the both group arms, either single agent or combination. Another trial, augmented trial, it is comparing single agent rituximab versus combined rituximab lenalidomide, but in relapsed or refractory indolent lymphoma, including follicular lymphoma patients. And this trial, as we see, showed more progression-free survival. In this trial, the maintenance duration, the maintenance treatment duration was 2 years more than the previous trials. And also the overall survival was the same in the both groups. So data confirmed in augmented trials using combinations that published in the 15th ICML showed rituximab R2 superiority in the patient with also POD24 patient or high risk that progressed within the first 2 years. Also, combination R square showed better response rate to the next therapy and the longer treatment period and the longer progression-free survival too. Also have no significant clinically meaningful impact on the quality of the life depending on this augmented trial. So, like this combination was moved to the first line to be assessed by the relevance trial, and this is one of the most important trials in the first line therapy by comparing rituximab chemotherapy versus rituximab lenalidomide, as we see in this the study design. But unfortunately, progression-free survival in the both group was the same, and this trial was a superiority trial. So it is a failure trial, but we can conclude from this trial and R square, it is another alternative to R chemotherapy on those patients who cannot tolerate the chemotherapy or have more side effects of the chemotherapy. And this is trial comparing the CR rate at 30 months in patient treated with rituximab lenalidomide, either in the SAC group for 6 months or the relevance trial in the first line setting. This graph shows the adverse event and the side effect. And as we see, most of the chemotherapy regimens showed neutropenia and cytopenia compared to the other comparator by using R square regimens that showed cutaneous reactions and skin rash. So chemo-free regimen doesn't mean toxicity-free. This is very important. By searching for combining another partner to rituximab and lenalidomide, we have a data from ibrutinib by combining this triple therapy, but this triple therapy showed a high incidence of the skin rash in the follicular lymphoma, reaching 82%, but the efficacy was similar to rituximab and lenalidomide in the same population. And also we have another triple therapy by using PI3K kinase inhibitors by adding IDLZ to the lenalidomide and the rituximab. Unfortunately, we have a critical hepatotoxicity profile by using this triple combination. And this is the ongoing trials of using rituximab plus another partners like immunotherapy, lymphomab, and other partners or monoclonal antibodies, and waiting result of these trials to compete adding the chemotherapy. So my conclusion from this slides, like we have rituximab that improved overall survival in the follicular lymphoma, also more intensive treatment in the follicular lymphoma, improved progression-free survival, but not improved the overall survival. So long-term benefit with single-agent rituximab in more than 30% of the patients, and this is enough to give these drugs or these drugs without chemotherapy may be efficient to the patient. Starting with rituximab as a single agent doesn't impair the long-term overall survival. R-square is another alternative option or potential new options for upfront treatment of the follicular lymphoma. Chemotherapy-free strategies should be further explored, and rituximab may still be the benchmark for these trials. Initial trials of the new compounds should use conservative designs in the futures. And thank you very much for your attention. Waiting for your comments and questions.
Thank you so much. It was a very interesting lecture. I like this tendency that we are going far away from chemotherapy and pay attention to new target drugs. Sometimes it's very interesting to wait and watch the lymphoma cases. It's also very hard and demands a lot of knowledge and skills from the chemotherapists, but it's also very interesting because as you said, that overall survival is the same, only progression-free survival different. So maybe sometimes it's too stressful to live with disease and not to do anything.
Yeah.
But very interesting. I like it. Is there any questions from the audience? Есть у кого-то вопросы к нашему профессору? Tomorrow is a holiday here. It's a teacher day. That's why not so many people here, but we record it and put it in our YouTube channel. I think it's very interesting and very useful for our students and clinical residents. So I hope you can come here in Uzbekistan someday.
Yeah, it's my pleasure. Yes, I have a lot of colleagues in Pakistan and in Georgia and in Tashkent. Like we really have a good partnership and collaborations. And this is one of the most important things in our community, especially in oncological community, to collaborate with each other.
Yeah, this month, at the end of this month, we are going to Egypt in Cairo.
Yeah. So
for breast cancer conference, it will be breast cancer conference. So I hope we can see each other. And
yes, you are welcome in our country.
You are welcome as well.
And welcome for everybody.
So I hope we will cooperate in the future. And I think if there is no questions, we can finish our lecture and hope to
thank you for the kind invitations. And really, I am grateful for this opportunity and impressed with your activity on the Facebook or on the OncoSchool dashboard. I hope you the success and future great one.
Thank you so much. So
thank you.
Bye-bye.
See you soon. Goodbye.